Hello, and welcome to the neurology portion of the CCR and exam. Now, the AACN groups this neurosection in with musculoskeletal and psychosocial to comprise about 13% of the exam. So that's going to be about 19 questions between each of those three sections, so of which you can expect to see about 10 plus or minus questions being related to neurology. Now, the testable nursing actions pertaining to neuro are as followed. You're going to need to be competent in monitoring patients and following protocols for neurologic procedures. That includes pre, intra, and post procedures. Most of those are going to be related to EVD placement or TPA infusion. You're also going to need to recognize indications for and managing patients requiring neurologic monitoring devices and drains. Those are things such as ICP monitoring, EVD, or ventriculostomies. So now again, most of the questions are going to be centered around how to care for the patient with increased intracranial pressure and what to do for these patient populations. So let's get started. Now, in the cranial vault, it's comprised of about 80% brain tissue, 10% cerebrospinal fluid, and 10% intravascular fluid or blood. Now, the brain requires a constant supply of oxygen and glucose. There's no muscle or fat to store glucose. So therefore, the energy necessary for the brain's metabolic functions is obtained from the oxidation of glucose. And all oxidative reactions are going to require oxygen. So now, when the patient is hypoxic, the cerebral neurons are only viable for about 4 minutes until irreversible injury occurs and the cells are destroyed. Now, the brainstem is the area of the brain most resistant to hypoxic damage. If hypoxia occurs in this area beyond the 4 to 5 minute limit, you're going to see an irreversible coma or a persistent vegetative state usually develops. Now, unlike most other organs or tissues, the brain doesn't require insulin to transport glucose. So, when your patient's blood glucose increases or there's an imbalance with sugar or oxygen, the brain metabolizes this excess sugar to glutamate, which produces lactic acid, which, as we know, is bad for the brain. So if the cerebral glucose level is less than 70, you're going to start to see some confusion. If the blood glucose is less than 20, you're going to start to see a coma develop and the patient can progress to death without intervention. Now, with an increased blood sugar of about 200 or greater, the blood viscosity increases, making the blood thicker, and the normal blood flow characteristics to the cerebral vasculature is going to be compromised. You start to become hyperosmolar, and the brain's going to start becoming more dehydrated. Now, we'll discuss that further when we get to our endocrine module. So the idea is it's important to keep tight blood glucose control in these patient populations. Now, let's review the Monroe-Kelly doctrine. So it's important to understand this concept. It's similar to understanding the Frank-Starling law as how it applies or how it relates to the cardiac function. So now the Monroe-Kelly doctrine is what's going to reinforce our understanding of the cranial vault. So the pressure-volume relationship between ICP, the volume of the CSF, the blood, the brain tissue, and cerebral perfusion pressure, this is going to all be known as the Monroe-Kelly doctrine or the Monroe-Kelly hypothesis. Now, the central nervous system and its associated fluids are enclosed in a rigid vault, basically your cranium, whose total volume tends to remain constant. Any increase in volume of one of the components, such as your blood, your brain, your cerebrospinal fluid, this is going to elevate pressure and decrease the volume of one of the other elements. So therefore, whether the insult to the brain tissue results from a focal impact or a diffuse axonal injury or an intracranial hemorrhage or the mass effect resulting from either of those, the syndrome we wish to avoid is increased intracranial pressure. Now, let's talk about cerebral perfusion pressure or CPP. The normal intracranial pressure values are going to be 5 to 15 millimeters of mercury, and the normal mean arterial pressure, as we all know, is about 70 to 105 millimeters of mercury. Generally, 70 is going to be that number that they're going to be referencing for the CCRN exam. You want to try to keep the mean arterial pressure around that value. Now, the normal cerebral perfusion pressure, or CPP as we know it, is going to be between 60 to 100 millimeters of mercury. So that's a very, very important value to understand and to comprehend, and we're going to talk about that a little bit further. So when we look at cerebral perfusion pressure as a value, how you derive that value is going to involve the MAP and the ICP. So now the MAP, as we know, is going to be between 70 to 105, and we know the ICP values are going to range between 5 and 15. CPP is going to equal MAP minus ICP, where changes in MAP or ICP can affect CPP. So the CPP values should be between 60 to 100 millimeters of mercury. Now, that's the pressure required for the heart to pump blood to the carotids up to your vertebral arteries to the circle of Willis. Then the blood from the circle of Willis has to go to the small arteries to the cerebral cortex. So now again, neurosurgeons prefer CPP, or cerebral perfusion pressure, to be at about 70. Now, normally cerebral perfusion pressure remains constant due to what's called autoregulation. And these numbers may vary from about 70 to 85 millimeters of mercury. Now, for those patients with an abnormal mean arterial pressure or an abnormal intracranial pressure, the cerebral perfusion pressure is going to be calculated by subtracting the intracranial pressure from the mean arterial pressure. Now, one of the main dangers of increased ICP is that it can cause ischemia by decreasing the CPP. As ICP approaches mean arterial pressure, cerebral perfusion is going to fall. Now, the body responds to this fall in cerebral perfusion pressure by raising the blood pressure and dilating the cerebral blood vessels. This increases the cerebral blood volume, further worsening ICP and starting a vicious cycle that's going to lower that CPP even further. Now, the brain has an intrinsic ability to autoregulate. This is what's called cerebral autoregulation. This is where the blood vessels constrict and dilate in response to environmental changes. Now, this mechanism of autoregulation fails when the CPP falls below 50 or it exceeds 150 millimeters of mercury. This is what's known as decompensation. So now when the brain loses its ability to compensate or autoregulate, pressure on the cerebral vessels slows or impedes blood flow to the brain tissue. This diminished circulation is going to lead to ischemia, where CO2 and lactic acid is going to start to accumulate. So then once that happens, hypoxia and hypercapnia, or elevated CO2, is going to lead to vasodilation, where this increase in blood volume produces brain edema. So now that when this happens, the ICP is going to go up, which is going to cause the cerebral vessels to compress, which causes further ischemia, and then therefore cerebral circulation is going to cease, ultimately progressing to brain death. Now, back in the day, CPP wasn't well understood. Keeping blood pressure low was thought to be the gold standard. Now, of course, today we know that a higher blood pressure is going to be preferred in this patient population in order to maintain CPP. So keeping CPP between 60 to 80 or systolic blood pressure less than 140 is what you can expect to see on the exam. But this is a very delicate balance. Of course, too much blood flow can increase ICP, which is not good, and of course, too little blood flow will reduce perfusion, which also isn't good. So when the patient sustains a brain injury with increased intracranial pressure, the idea that you're looking for is adequate blood flow. So now let's look at some of the causes of increased intracranial pressure. Now, one of the primary things that's going to increase intracranial pressure is hypercapnia and hypoxia. You want to keep the PaCO2 normal, or about 35 to 40 millimeters of mercury. You want to keep the PaO2 greater than 80 millimeters of mercury. If the PaO2 falls to below 60, this is going to cause arterial dilation of the cerebral arteries, which increases blood flow. This, of course, as we know now, leads to increased intracranial pressure, which in the diseased brain is going to be dangerous. Now, hypocapnia, which is PaCO2 less than 35, is going to cause arteriolar constriction of the cerebral arteries, which reduces blood flow and oxygen. So balancing the PaCO2 is very, very important in keeping the cerebral blood flow at that optimum state. So in understanding when you need to keep cerebral blood flow at an optimum state, one of the questions that you may see on the exam is going to pertain to endotracheal tube suctioning. You may see a question that relates to the nurse performing endotracheal tube suctioning frequently, which is not going to be the right answer. In these cases, or in these patient populations, you want to space out that ET tube suctioning, because each time you do that suctioning, you're going to increase that CO2 level in the patient, which we know now is not good for these patient populations. Another thing that's important to keep in mind is you want to avoid giving these patients hypotonic fluids such as D5W, as those types of fluids are going to cause the cells in the brain to expand, which is going to promote cerebral edema. That's why when you see in these patient populations, some of the patients are going to be given rather hypertonic fluids such as mannitol or 3%. These types of fluids are going to cause the cells in the brain to shrink and to help reduce that cerebral edema, which is going to help promote healing in these patient populations. Another thing that increases intracranial pressure is going to be hyperthermia. This increases the brain's metabolic rate, which increases oxygen demands, therefore increasing the cerebral blood volume. So it's very, very important to keep these patients normothermic. Another cause of increased ICP is going to be from mass lesions or space-occupying lesions such as tumors, hematomas, or hemorrhages from traumatic injuries or spontaneous bleeds. Now, we're going to discuss these types of brain injury further in just a moment. Another potential cause of increased ICP is the impairment of venous drainage through the jugular veins or that arterial blood flow through the carotid arteries. So some of the things that the nurse needs to keep in mind is you need to keep those patients with neutral neck alignment, and you want to avoid IJ central lines. Another thing to do is maybe make sure those trach ties aren't too tight, and as well as those C-collars, those patients with your C-collars, make sure those are properly fitted. It's important to keep the head of bed elevated. You want to avoid hip extreme flexion or a prone position or Trendelenburg. Another thing is also to avoid straining while stooling. So usually these patients with neuro injuries are prescribed a very strict bowel regimen. So again, there's many things that can cause increased intracranial pressure in these patients. So things to keep in mind again, avoid oversuctioning these patients, avoid stressful environments, even bright lights, noise, or even painful or nauseous stimuli are all going to contribute to increased intracranial pressure in these patients. And it's very, very important as the nurse to maintain that type of environment that helps promote decreasing intracranial pressure. Now let's look at some of the types of brain injury that your patient can sustain. So you've got two different types of injury. You're going to have primary and you're going to have secondary injury. Now the primary injury is going to be related to a direct injury, such as a motor vehicle accident, coup contre coup, concussion, contusion, or a penetrating brain injury. Now a secondary brain injury occurs basically secondary to another problem. So some examples of these are going to be hypoxia, inflammation, edema, a decrease in CPP, etc. Now let's talk about strokes. On average, someone in the United States suffers a stroke every 4 seconds and dies from a stroke every 4 minutes. It's also one of the top 5 leading causes of death in the United States, according to the CDC. Now, it's also the second leading cause of death in the world. So there's two types of stroke. You're going to have ischemic and you're going to have hemorrhagic. So let's talk about ischemic stroke now. Ischemic stroke counts for 87% of all cases. This is according to the American Stroke Association. So an ischemic stroke now is a sudden and severe disruption of the cerebral circulation with the subsequent loss of neurologic function. This can be caused by either a thrombus or an embolus. Now, the difference between a thrombus and an embolus is very, very important to be able to distinguish. Basically, a thrombus is going to be that clot that forms in a vessel, and then of course it becomes an embolus when it breaks off and travels in the bloodstream. So now the management of this situation is going to involve rapid identification, triage, and diagnosis. So those of you that are working in stroke centers or are stroke certified are going to be familiar with the acronym FAST, or F-A-S-T, where F is going to be facial asymmetry, A is going to be arm and leg weakness or numbness, S is going to be abnormal speech, and then there's T, which is going to be the most important factor, which is time for the TPA window, which is going to be 3 hours to be able to know whether to give TPA or not. So now TPA is tissue plasminogen activator. This is an enzyme found naturally in the body that converts plasminogen to plasmin, which is going to dissolve blood clots. We can also give it synthetically via IV infusion, and that's that miracle drug that they talk about when you look at the treatment of strokes nowadays. Now, there's different eligibility criteria for these patients, such as you need to be 18 or older, you have to have a measurable neurologic deficit, and the CT scan needs to be negative for a hemorrhage or a non-stroke cause of this deficit. It's important to understand that the time of onset, or that window of treatment between recognition and the infusion of TPA, needs to be within 3 to 4.5 hours. Very, very important, because anything after that is going to be another exclusion for that TPA. And one of the Joint Commission core measures is going to be achieving door to needle time within less than 60 minutes. So now there's many more contraindications for getting TPA infusions, such as any form of intracranial hemorrhage or an active internal bleed, recent head trauma or surgery, the presence of an AV malformation or aneurysm, low platelet counts, or even if the patient is on warfarin, that's going to preclude them from getting TPA. Now, one of the things that you need to know for the exam is you need to keep that blood pressure less than 180/100 for the first 24 hours after TPA infusion. So it's important to understand that those patients that are excluded from getting TPA, you can maintain their systolic blood pressure less than 220 and their diastolic blood pressure less than 120. And this is going to be the acceptable range for patients with an ischemic stroke. Anything over that blood pressure, and you can treat with a beta blocker or a calcium channel blocker such as labetalol or nicardipine. Now, adequate cerebral perfusion pressure is imperative for these patients. Close neurologic monitoring after TPA infusion is going to be vital for these patients. So it's not uncommon to see written in a hospital protocol frequent neurochecks, such as every 15 minutes for 2 hours, every 30 minutes for 6 hours, and every hour for 16 hours. Generally, these patients are going to be a one-to-one patient assignment, and you're going to be performing that NIH stroke scale. Now, this scale is important to have as a baseline score because afterwards, the focus of the assessment is going to shift to monitoring for those neuro changes and deterioration. So now, evidence shows that the condition of approximately 25% of patients is going to worsen during the first 24 to 48 hours after a stroke. So the NIH-SS, or the NIH stroke scale, is going to provide a numerical value for comparison from one time period to the next. So generally, it's important to first establish that baseline score, then 2 hours after treatment, and then 24 hours after the onset of symptoms, and then you can progress every 7 to 10 days to up to 3 months. And these scores are going to range from a 1 to 4, meaning a minor stroke, all the way up to a 21 to 42, which is going to indicate a more severe stroke. Now, we don't need to get into the details of how to perform the NIH stroke scale, but it's important to understand that that scale is something that's an expectation. Now, some of the other invasive methods of treating ischemic stroke, in addition to TPA infusion, are going to include an endarterectomy or a carotid artery angioplasty, and even more common now is going to be an embolectomy or a clot retrieval. This is going to be performed after the administration of TPA. Now, we're starting to see some really great outcomes to this new approach with these clot retrieval systems to treating strokes. So let's review. The two types of strokes you're going to have are going to be ischemic and hemorrhagic. We just talked about ischemic. Now the second type of stroke is going to be hemorrhagic stroke. Now 13% of all strokes are going to be hemorrhagic, but they're going to be responsible for 40% of all stroke deaths. The most common hemorrhagic stroke happens when a blood vessel inside the brain bursts or leaks blood into the surrounding brain tissue. This is what's known as an intracerebral hemorrhage. This bleeding causes those brain cells to die, and the affected part of that brain is going to stop working correctly. High blood pressure and aging blood vessels are going to be the most common causes of a hemorrhagic stroke. So now, of the hemorrhagic strokes, there's 3 types that you need to know for the CCR and exam. You need to know intracranial, intraventricular, and subarachnoid. Now, an intracranial hemorrhage just means all bleeding that occurs within the cranial vault. Intracerebral or intraparenchymal is going to be used interchangeably. And basically, this just means bleeding within the functional brain tissue. Now, depending on the location and the size of the bleed is what signs and symptoms are going to manifest. Now, we'll look at that further in terms of signs and symptoms and what manifests when we talk about the different types of herniation. Now, an intraventricular hemorrhage is going to be bleeding within the brain's ventricular system where the CSF, or the cerebral spinal fluid, circulates. Generally, the outcomes are going to be worse if there's not an immediate treatment. So statistically, the expected mortality of these is going to be between 50 to 80%. Some of the signs and symptoms that you can see with the intraventricular hemorrhage is going to be nuchal rigidity or neck stiffness, photophobia, hyperthermia, and a positive Koenig's and Brzezinski's sign. So it's important to understand for the CCR and exam the difference between the Koenig's and the Brzezinski's sign. Both of these tests are non-invasive, and they're going to help confirm some sort of meningeal irritation or an intraventricular bleed. Basically, a positive Koenig's sign or Brzezinski's sign is going to indicate meningeal irritation, intraventricular hemorrhage, or even meningitis. Now, the second type of hemorrhagic stroke is going to be a subarachnoid hemorrhage. Now, the subarachnoid hemorrhage basically is bleeding in the subarachnoid space. This is that CSF-filled area between the brain and the tissue covering the brain. Now, it's important to know for the exam that the majority of subarachnoid hemorrhages are going to be from ruptured aneurysms. These are the types of patients that come in complaining of the worst headache of my life. You're immediately going to suspect a subarachnoid hemorrhage. You might also see altered level of consciousness or seizure activity. Now, hypertension is also going to be a cause. This is basically present in 90% of cases. These are going to be treated with surgical clipping or coiling. Now, an AV malformation is going to be basically a tangle of abnormal arteries and veins. This is thought to be congenital, and the patients may complain of a swishing sound in the head with each heartbeat, or a bruit. The gold standard for ruling out an AVM or an AV malformation is going to be an angiography. You might also see a CT scan or an MRI performed for these patients. Now, the treatment for these are going to be surgical, such as an endovascular embolization. This is where a catheter passes through the groin into the cerebral artery, and it's going to inject a material or maybe even a glue to clot off that blood supply to that tangle of vessels. And then, of course, later it's going to be resected. Now, other types of hemorrhage are going to involve a hypertensive rupture, a vascular tumor, and then we'll discuss in a moment a traumatic brain injury. Can be also caused by fibrinolytics such as TPA, anticoagulants such as your heparin and your warfarin, or bleeding disorders such as hemophilia or sickle cell or von Willebrand's. Now, it's very, very important for you to understand that the leading cause of mortality and morbidity in patients who survive the initial bleed is going to be cerebral vasospasms. Now, vasospasms occur in up to 70% of patients after a subarachnoid hemorrhage and occurs generally within 3 to 15 days. Now, there's an extensive pathophysiology that occurs in a vasospasm, but for the purposes of the CCR exam, you just need to know that they are common after a subarachnoid hemorrhage and how to prevent them. So now the primary prevention of a vasospasm is going to be the surgical removal of the subarachnoid hemorrhage and then the treatment postoperatively with calcium channel blockers. And the drug of choice for this is going to be nimodipine. You can either give this in pill form or you can give it as an elixir through the NG tube if these patients can't swallow. Now, nimodipine is known to have some selectivity for the cerebral circulation, and it's going to be given every 4 hours for about 3 weeks after the surgery. Another more controversial modality that they're actually getting away from, but it's still important to know, is Triple H therapy. This is known as hypertensive hypovolemic hemodilution. Basically, you want to maintain the systolic blood pressure between 120 to 150, and you want to maintain a CVP between 10 to 12, as well as maintaining a hematocrit between 30 and 33, and a serum osmolality between 275 to 290. This basically is going to produce that fluid stent, which is going to help increase CPP and cerebral blood flow. Now, there's other evidence out there now that supports the maintenance of euvolemia as opposed to hypervolemia. So it's important to understand, though, that hypotension and hypovolemia are what we wish to avoid completely. Now, let's discuss some of the different types of neurotrauma that you're going to need to know for the CCR and exam. let's talk about the different types of skull fractures. The most common one is going to be a linear skull fracture, which accounts for about 80% of all skull fractures. These involve your epidural hematomas, which is a swollen or ecchymotic area of the scalp. Now, the rapid decline of these patients is what's going to require rapid intervention. The next one is going to be your subdural hematoma, which is a little bit more acute, and it's going to require surgical decompression. So the treatment is going to be somewhat like a burr hole or the removal of a fluid surgically, and you may see these patients come back with a JP drain. So it's important for those patients that you want to keep the head of bed flat for about 1 to 2 days so that it can be depressed. Another type of fracture is going to be a depressed fracture, which can cause a brain laceration or an ICH. And then the next type is a basal skull fracture, which is an injury to one or more of the cranial nerves. Now, this is a tearing to the dura with a CSF leak. So some of the things that you can see with the CSF leak are going to be rhinorrhea, or CSF from the nose, or otorrhea, which is CSF from the ear. Hallmark sign of that is what's called a halo sign. Or you can see raccoon eyes. Patient can have a lost sense of smell. Basically, this is from damage to cranial nerve 1, which is the olfactory nerve. You might also see what's called a battle sign, or bruising behind the ears. For those patients with a basal skull fracture, it's important to avoid nasopharyngeal airways or nasal tube suctioning or the insertion of nasogastric tubes. Another type of injury is a closed head injury. This is what's known as a contusion or a more localized bruise. This can be known as, this is where you'll see your coup contra coup injuries. This is a high impact injury causing a cerebral contusion to the site of impact as well as the opposite side of the brain. That's where your coup contra coup comes into play. These are common in your motor vehicle accidents. These can also cause concussions, which is more of a global injury. This is where a transient state or a partial or total paralysis of cerebral functioning. You're going to see a temporary loss of consciousness or a memory loss. Generally, though, they usually recover within 12 hours or so. Now, also, there's going to be your sports-related injuries, and then you can move on to your diffuse axonal injuries. And this is where the mechanical disruption of axons and neuronal pathways occur in both hemispheres of your brain. These generally last greater than 24 hours, and you're going to see some more permanent residual deficits. You're going to lose your memory, and you're going to have some cognitive dysfunction as well. And these generally have a much more higher mortality and can result to a persistent vegetative state. Okay, so let's talk about some of the different types of infection you can expect to see in neuro patients. The first one being bacterial meningitis. You're going to have bacterial and you're going to have viral. So in bacterial meningitis, generally it's caused by an ear infection or sinusitis, upper respiratory infections, pneumonia, penetrating head injuries, or more surgical procedures or invasive ICP monitoring. These complications are going to be much more severe with patients with bacterial meningitis. You need to put these patients on droplet precautions. You need to understand the different signs and symptoms of it, which are going to be altered mentation, seizures, or any sort of inflammation in the CNS. You can expect to see a petechial rash on the trunk or the mucous membranes or the conjunctiva. Now, the takeaways for differentiating between viral versus bacterial meningitis you can expect to see on the CCRN exam is understanding that the CSF studies in bacterial meningitis are going to have low glucose and very high protein, and the CSF is going to be cloudy. So if you think about it, perhaps when you're assisting the physician to do a lumbar puncture, and they withdraw the CSF, if you see that the CSF is cloudy, you can probably suspect more that it's going to be a bacterial sort of infection versus in viral meningitis, the CSF is still going to be clear. So one of the things that you can think about to remember is you can think of bacteria, they basically are going to eat sugar and they're going to excrete protein. So in the studies of bacterial meningitis, the difference is you're going to see low glucose and very high protein in cloudy CSF. So now in viral meningitis, these are going to be more prevalent in your immunocompromised patients. You'll see these with mumps, measles, influenza, West Nile. These are more common viral infections. The symptoms are going to be less severe than bacterial, and they're generally going to improve within 7 to 10 days. So again, the CSF studies are going to be normal glucose, still going to see some high protein, but not too high, and the CSF is going to be clear. So now some of the signs and symptoms of a viral meningitis are going to involve a headache, altered mentation again, nuchal rigidity or stiff neck. You'll see seizures in these patients, and then of course one of the hallmarks being the positive Brudzinski's and the Koenig sign. So now let's discuss some of the neuromuscular disorders that you're going to need to know. These are primarily going to involve myasthenia gravis and Guillain-Barré syndrome. Now, myasthenia gravis is a chronic autoimmune neuromuscular disease. So in differentiation with myasthenia gravis, this is going to be a generalized muscle fatigue and weakness, which is brought on by activity. This is going to be involving more skeletal muscle, and it's also going to involve your extraocular muscles as well. Basically, the acetylcholine receptors are going to be blocked at the neuromuscular junction. And then the other important thing to know is that symptoms improve with rest. And then the pharmaceutical treatment is going to be with a drug known as Mestinon. It's important for the nurse to monitor for respiratory failure and swallowing impairment in these patients with myasthenia gravis. Now, Guillain-Barré disease is also an autoimmune disease, but this involves the destruction of the myelin sheath surrounding the nerve axons. There's basically an impaired ability to transmit nerve impulses. So some of the symptoms you're going to see are areflexia and motor weakness. This generally also involves an ascending paralysis, which starts in the legs and travels all the way up to the cranial nerves. So it's very important for the nurse to monitor the patient closely for respiratory failure because of weakness of these respiratory muscles and their inability to protect their airway. Their vital capacities are going to be decreased. They're going to have a weak cough with dyspnea. They're also going to have abnormal ABGs. But generally, there's a good prognosis for these patients. So let's look at the different types of herniation now. When considering brain death, you may need to know the different types of herniation, one of them being a supratentorial herniation or an uncal herniation. This involves an expanding lesion in the temporal lobe of your brain, which is lateral displacement of the uncus over the edge of that tentorium. One of the signs and symptoms that you'll see in this type of herniation is ipsilateral or same-side pupil dilation. This is where pressure on cranial nerve number 3, which is your oculomotor nerve, this can affect the parasympathetic stimulation to the eye. So one of the key points to remember is parasympathetic stimulation causes pinpoint pupils, whereas sympathetic stimulation causes dilated pupils. Other things that you might see in this type of herniation is, of course, decreased level of consciousness, respiratory pattern changes, or posturing. Now, central herniation is any expanding lesion in the frontal, parietal, or occipital lobes of the brain, or just a generalized edema, which causes a downward displacement through that tentorial notch. This causes pressure on the midbrain, and some of the things that you'll see are going to be small but reactive pupils progressing to fixed and dilated pupils. You're also going to see hyperventilation and or decorticate posturing to flaccid extremities. This is where the Cushing's triad is going to come into play. Now, an infratentorial herniation is the downward cerebellar or tonsillar herniation through the foramen magnum. So now the assessment is you're going to see complete unresponsiveness, you're going to see a full absence of cerebral motor responses to any sort of pain or nauseous stimuli, full absence of brainstem reflexes, you're not going to see any pupillary light reflexes, no corneal reflexes, no cough gag reflex, and they're not even going to have any sort of spontaneous ventilation. These patients are going to see in a full coma, they're going to see flaccid paralysis, you'll see respiratory and cardiac arrest, and this is where full brain death is going to occur in these patients. This is where the apnea test comes into play. So now the oculocephalic reflex, or the doll's eyes. This tests cranial nerve 3, 6, and 8. This is where you rotate the patient's head side to side. Now, the normal finding for the doll's eyes reflex test is if the eyes are going to move in the opposite direction of the head turn. An abnormal finding is if the eyes stay midline or turn in the same direction as head movement. Another one is called the oculovestibular reflex, which is caloric testing. This is where the physician injects 20 to 50 milliliters of ice water into the patient's ear. The normal finding is if the patient looks to that deviated ear, or an abnormal finding now is if you don't see any eye movement. Now, the formal determination of brain death is going to require 2 physician signatures. Let's talk about the nursing assessment and the neurologic examination for these types of patients. The assessment is going to involve a more focused neurologic exam. You're going to be watching for any sort of behavioral changes in these patients. Watch for early agitation or any change in mental status such as confusion, restlessness, lethargy, or even a coma. And you remember the GCS less than 8, you want to intubate. It's always something to remember. You also want to look at the motor function of these patients. It's important that they have voluntary bilateral grips, arm raises. You want to look for their foot strength, any changes in gait, etc. In neurologic patients is going to involve any sort of plegia versus a paresis. So plegia meaning weakness versus paresis, which involves paralysis. So now more a late decline or a late sign of decline is going to involve posturing. This is basically a decorticate posturing. Is any abnormal flexion, which indicates some sort of cerebral lesion, to decerebrate, which is basically going to be an abnormal extension. This indicates more of a midbrain or a brainstem lesion. You're also going to look for sensory function, any sort of patient responses to nauseous stimuli. These can be any sort of the reflexes, cough, gag, corneal reflexes. You also want to look at the cranial nerve assessment. Now, you don't need to know all 12 cranial nerves for the exam. You just need to know which cranial nerve is going to be responsible for pupillary function. And this is going to be the oculomotor nerve, which is cranial nerve 3. And again, it's important to know that the parasympathetic system is going to constrict the pupils. So if cranial nerve 3 is compressed, you're going to see the pupil dilate. You need to know pupil changes. Small and reactive, progressing to fixed and dilated, again, is going to involve central herniation, whereas the uncal herniation is going to involve ipsilateral dilation, which progresses to bilateral and fixed pupils. You also need to know the cranial nerves involved with swallowing. These are going to be the cranial nerves 10, 11, and 12. The vagus nerve, which is 10, the spinal accessory, which is 11, and the hypoglossal, which is 12. You also need to know the Cushing's triad, which is a sign of high intracranial pressure. This is your irregular respirations, your bradycardia, and your widened pulse pressure. This is basically blood pressure with increased ICP, which puts pressure on the brainstem, causing a widened pulse pressure, or basically a higher systolic blood pressure with a lower diastolic blood pressure. Now, the Cushing's reflex, this is a late sign of increased ICP. The respiratory rate's going to be lowered, which is going to indicate CNS depression. You're going to see decreased tidal volumes. You're also going to see what's known as bradypnea, or decreased respiratory rate, which is also going to increase the CO2. And as we talked about earlier, that's a bad thing for these patients. So these patients are going to need to be intubated, and their respiratory rate's going to need to be increased to blow off that CO2. You might see Cheyne-Stokes breathing, which is an increased rate and depth followed by a decreased rate and depth, a different type of breathing pattern. Also neurogenic hyperventilation. This is an increased rate with a large tidal volume, which is also leading to hypocapnia, which is a PaCO2 less than 25. Again, these patients need to be intubated and sedated. Another type of breathing pattern is what's known as ataxic, which is basically no pattern. It's a completely irregular pattern with mostly periods of apnea. Okay, so now as we wrap up with the neurology module, it's important to remember the general nursing care for these patients, your ABCs. If the GCS is less than 8, you want to intubate. Airway and ventilation is important. Keep the PaO2 greater than 80 and keep the PaCO2 in between 35 to 45. It's also important to keep the ICP less than 20. So you want to do things like drain that CSF, keep a quiet environment, maintain sedation and analgesia, as well as seizure prophylaxis. You can also give mannitol, hypertonic saline to these patients. You also want to keep the CPP greater than 60 to 80 millimeters of mercury. So keep the head of bed at 30 degrees with neutral neck alignment. Keep those carotid arteries patent. Maintain temperature control. So keep these patients normothermic. You also want to promote nutrition, so things like a feeding tube if indicated, or post-pyloric feeding tubes. It's important to keep these patients euvolemic. You also want to prevent aspiration in these patients. And of course, keep them NPO until the swallow assessment is done. You also want to recognize the risks for and prevent infection, DVT prophylaxis such as blood thinners and SCDs, importance of bowel and bladder regimens such as your Foley, your laxatives, stool softeners. You want to avoid straining for these patients, which helps to decrease ICP. And of course your PT-OT for promoting early mobility when it's indicated. So that wraps up the neurology module for the CCR and exam. We thank you for your participation, and I will see you in the next module.